Hello, everyone. So we are continuing on our type 2 diabetes journey. And I just talked about assessments, subjective and objective assessments that we work through with our clients who are diagnosed with diabetes mellitus to be able to help them reach their health goals. So possible nursing diagnoses is the next slide here. So let's talk about that. So nursing diagnoses that are associated with diabetes mellitus, type 1 or type 2, include a lack of knowledge. So there's a lot of education that goes into working with people with diabetes. That's why we have a specialty unit called diabetic nurse educator, as well as some other different specialties that help out with this particular set of pathophysiologies. Teamwork definitely makes the dream work when it comes to people with diabetes. Other problems that we can have with people who have lack of insulin, we can either have hyperglycemia. I talked a lot about hyperglycemia earlier, where there's way too much blood sugar in the blood and all the different problems and all the different manifestations that come from them. We can also have hypoglycemia, where we have enough insulin, they just didn't have blood sugar to be able to move. Because of these blood sugar changes and a lack of knowledge, it puts these people at an increased risk for injury, both for tissue damage. It puts them at a risk for hypoglycemics, can pass out. People with diabetic ketoacidosis and I can't remember, the hyperosmotic syndrome, HHS, sorry, they can also have a lot of problems with risk for injury as well, because the brain chemistry is off, because their blood chemistry is off, in essence. There's also impaired peripheral neurovascular function, and that comes from, again, when I was talking about labs and things, those little crystals, that little blood sugar, it's not just like a squishy sort of thing. It goes into the bloodstream as a little tiny crystal brick of stuff, and it nicks and damages all sorts of different peripheral vascular capillary beds along its way, and creates a great number of problems in the vessels because it is so sharp, and those sharp edges are cutting the vessels as it passes through. When we're setting together some plans, we're putting together a care plan and doing some goals. People who are diabetic really do need to engage in their self-care behaviors and actively manage their diabetes. It is really tempting for people to sometimes offload this responsibility onto other people, but we can teach people who are not severely cognitively impaired about how to manage this themselves, but they do need to take ownership. A great goal is to have few or no hyper or hypoglycemic emergencies. Let's keep that blood sugar in the sweet spot and let's leave it there. Maintaining normal or near normal blood glucose levels, again, keeping that blood glucose in the sweet spot. Preventing risk for chronic complications, and adjusting lifestyle to accommodate diabetes plan with minimum amount of stress. This can be a really overwhelming, daunting process for people. So helping them walk through that and not increase their stress would be awesome, especially since stress increases blood glucose, which changes your insulin. So nursing implementation. Let's start out with promotion. So an ounce of promotion is worth a pound of cure, right? Identify, monitor, and teach patients who are at risk. So obesity is the primary risk for type 2 diabetes. A 5 to 7% weight reduction and about 50 minutes of exercise per week can lower the risk of type 2 diabetes 34 to 58%. So a little bit of weight reduction and increasing the activity level has profound effects on your risk for developing type 2 diabetes. Routine screenings for overweight or obese adults over the age of 45 with one or more risk factors, which is in a table in the textbook. And if that's normal, it's our every 3-year repeat. It's not like an every 6-month thing, it's like an every 3. Risk factors include, it's a quick summary of table 4813, age, ethnicity, obesity, having a baby greater than 9 pounds at birth, history of gestational diabetes, and a family history of diabetes. There's also a diabetes risk test that if you wanted to take it, you sure could. This link is active. And then you can also see promoting population and preventing diabetes. As well, let's get into acute care. This is kind of where my meat and potatoes were. Sorry, this is a typo. This is not term 4, it's term 3. But acute care situations like hypoglycemia, diabetes we'll cover today, or in our class this week. But high acuity in term 3 will cover diabetic ketoacidosis and hyperosmotic hyperglycemic syndrome, HHS. This is why I was having a problem on the previous slide. So hyperosmolar hyperglycemic syndrome, HHS, which is a hyperglycemic crisis for people with type 2 diabetes. Diabetic ketoacidosis is a hyperglycemic crisis for people with type 1. There is a direct relationship to stress and having problems with your blood sugar. Stress is AKA, otherwise known as illness, otherwise known as surgery. So physical and emotional stress causes increased glucose. Stressful situations such as acute illness, injury, or surgery requires more intense treatment to maintain glycemic goals. Blood glucose levels increase secondary to counter-regulatory hormones. So regulatory hormones that help out with stress, like cortisol, like epinephrine, they increase the blood sugar level. That is not great for a person with diabetes. So if we have somebody who's under stress in the hospital, undergoing surgery, having acute illness of a different reason, it can completely, maybe they have a really bad infection. It causes their blood sugar levels to raise, and it causes their hyperglycemic problems. And so a lot of times people would be, remember when I was talking about drugs? People will get shifted from their oral medication to sliding scale insulin in the hospital on a regular basis to be able to counteract this increase of blood glucose levels because they're in a stressful situation and producing more blood sugar. Diabetics should check their blood glucose every 4 hours during times of illness. So if for whatever reason you have somebody who gets influenza, the COVID, any sorts of nausea, vomiting, maybe they get some gastroenteritis. If the blood, they should be checking their sugars more frequently when they are sick, every 4 hours. And if the glucose is greater than 240, let's check their urine and make sure they don't have any ketones in it. And there's special little dipsticks that they can use to, once they do a catch of their urine, they can use a dipstick and see if there's any ketones in there. If they have 2 consecutive glucose levels greater than 300, or after they pop the greater than 300 and they check their urine ketones, then they come up moderate to high according to the color stick. They should be reported to the healthcare provider. They can be calling into the clinic. They can be calling into urgent care to meet with a provider. There are times where people with type 1 diabetes will have a prescription for a temporary increase in their insulin to help avoid diabetic ketoacidosis. And then that increased glucose increases risk of infection and reduces healing. So it really can be a very negative cycle where they've got an infection, so they're under stress, they're releasing more blood glucose, but then that reduces their healing. So then the infection can get really, really advanced very fast, much faster than a person who does not have diabetes. So we really do need to keep a little bit better vigilance and teach them how to be vigilant on their own, so that hopefully they can avoid being in the hospital and being a patient of Nurse Jeff. Type 2 diabetics may require insulin to treat high glucoses and avoid a hyperglycemic emergency. Critical ill clients may have a higher target goal of 140 to 180, and they may be getting insulin if their glucose is consistently greater than 180. This is going to be provider protocol. This is not necessarily something that We as nurses are going to be prescribing. We can definitely recommend, but we will not prescribe, and this is a provider judgment call. When people are acutely ill, we are going to help them maintain their diet if they're able to. If they can increase their non-caloric fluids, that will help a lot. So drinking water really, really helps. They should be continuing their diabetic medication regimen. If for whatever reason, like let's say they've got some nausea, vomiting, gastroenteritis situation going on, and their eating is less than normal, if they can supplement with carbohydrate containing fluids and continuing those medications, that's the best. That's the second best. It's not as ideal as being able to maintain a normal diet, but if they can't eat or drink, like let's say everything's just coming well every which way of their GI system, and nothing is staying down or in, they need to get a hold of their doctor and see if they don't need to come in for additional, or into the hospital for additional interventions. If a person with diabetes is getting surgery, usually surgery requires, especially if it's a scheduled surgery, they require, you can't eat, right? We just got done talking last week about different operative considerations, and one of them in pre-op is whether you've been eating or not. But people with diabetes need to be eating, and what do we do? So IV insulin and, or not, sorry, IV fluids and insulin when people are NPO is, we're going to be flipping them to insulin. We're going to take them off their metformin. Remember, we're going to hold metformin and their anti-diabetic medications for at least 48 hours before surgery. Then we'll temporarily move them on to Accuchex and insulin. And it's not a sign of worsening diabetes. It's just a way to manage this surgery period. If for whatever reason we have an unconscious patient, then we're going to be doing frequent monitoring of blood glucose. And this unconscious patient isn't, a lot of times people who have diabetes are able to verbally, or they're able to feel when they have hypoglycemia, and then they're able to verbally report. Person who's unconscious doesn't have that. So we'll be monitoring them for signs of hypoglycemia, such as diaphoresis, otherwise known as sweating, tachycardia, pallor, and tremors. Pallor is where they're really super pale. Like the worst blood sugar I've seen in my whole life. He came back from the cath lab and he had a sugar of 45. He was as white as the sheets, legitimately as white as the sheets. He was flat, like just like sweat everywhere. Not like wrench out rain sweat, but just like, he was cold, he was clammy, he was white, his heart rate was fast, he was not tremoring. But he had everything else going on that I have listed there. In ambulatory care, our overall goal is to ensure patients to reach their optimal level of independence in self-care activities. May or may not need caregiver help, depending upon their age and their cognitive level. So successful outpatient diabetes management requires ongoing interaction with the interprofessional team, including the certified diabetic educator. Many challenges to face with risks for chronic conditions that impact self-care activities. So we really need to be having some great conversations and some really good communication and some good trusting relationships with our patients who have diabetes when they are in the ambulatory care setting. The nurse's role in ambulatory care is to assess the patient and caregiver's abilities to perform blood glucose monitoring, SMBG is blood glucose monitoring, and insulin injection. And then if they need assistive devices and to refer them to resources for that, heck yeah. Insulin can be expensive. Glucose strips can be really expensive. The little lancets that we use with the glucose strips can also be really expensive. So if we can either help them find resources or refer them to social work and case management to help them find, and those people can help them find resources to be able to afford this, this is a really big deal. At this point in time, I am unaware that the price of insulin has been capped to a certain amount per month for Medicare, but I know that is on the table for discussion for law. And I believe the current cap that's being discussed is a client caps out per month at $35 a month for insulin. That's huge because insulin right now, without a cap, can cost $200 to $300 a month. just for the medication alone, let alone all the supplies that go along with it. Self-management requires dedication of time and energy to deal with lifestyle choices. Diet, medication, exercise, and preventing or managing complications are all part of that self-management. And it does require a lot of cognitive ability. It requires energy. It requires time. Whenever people are being asked for time and energy and cognitive, there's a high potential for frustration. So we also end up supporting them in their psychosocial transitions into this new sort of life, that to be able to meet their health goals. So part of the education that we're going to be giving is, what does it mean to them to have diabetes? Because that's a big deal. If that is like, okay, it's no big deal, I can do this, I got this, I've seen people do this, I can manage this myself. Or all the way up to, I hate needles, I don't want to have to poke myself, it hurts, I don't want to have to do it, I'm not doing it. And everywhere in between. So what does it mean to them to have this diagnosis is a huge conversation. Determining mutual goals that are based on the patient needs and the treatment plan. Identifying and including support systems in planning, teaching, and counseling. So helping that client meet those goals, or providing the care when the client is unable. They will need some support system. Teamwork makes the dream work, not just with the interprofessional team and the people who are wearing the scrubs and have the licenses and are in the facilities. They also help, if we could get a little support system at home, that goes a long way too. It also helps them to get some emotional support and encouragement as well. Insulin therapy for the nurses' responsibilities, because a lot of our responsibility in ambulatory care is helping them with their insulin, not necessarily giving them their insulin. That's what I did in acute care. This is ambulatory care. So we're going to help them properly monitor. We're going to check for proper administration, and we're going to be looking at the patient's response. We can provide patient and caregiver education. If you have access to a certified diabetic educator, please use them. And these certified diabetic educators will help people learn how to monitor glucose, how to keep accurate records. And when they're keeping accurate records, it's not just like my blood glucose was this, I gave this many units. Like if we can get them to keep some sort of diary about their insulin, their food, and their activities and their glucose levels, that gives that much more information about how we can custom tailor their plan so that they can have the best success. How to prepare and inject insulin is big. Addressing abilities, fears, beliefs, and concerns is really big. And how to identify hypoglycemia and what to do when you have when you fear that you have a hypoglycemia thing going on. When it comes to oral and non-insulin injectable agents, so the oral tabs or some of the different injections that people can give, our responsibilities become proper monitoring, administration, and patient response, very similar to insulin. We're also going to be working with them on caregiver education, diabetes management, prevention of complications, and then determine the most appropriate drug for the client. So remember, if you remember in drugs, I was talking about my friend Lynn when she started metformin and she ate applesauce for 6 months because she couldn't keep anything else down or tolerate anything else. We need to make sure that we're giving their most appropriate drugs for the client, because if they are the most appropriate drugs, there's a higher incidence rate of adherence, and the better the goals are. So we're going to need to consider a few different things: mental status, eating habits, home environment, learning ability, resources, attitude, and other medications. There are a variety of different other medications, including psych medications, that can influence patients' blood glucose and therefore influence their ability or their tendency to develop type 2 diabetes. So if we can help them determine the most appropriate drug combinations to be able to get them mentally healthy, physically healthy, glucose healthy, everything it's easier, much easier to reach our health goals that way. The other thing that we need to work with people about getting some education and doing some things. So this is a lot, right? They have to learn all these different new meds and how to do them and when to do them and what to do with them. They have to do all the 7 rights of medication for themselves. They have to do lifestyle changes where they have to exercise more. They have to do dietary changes where they have to eat more fruits and vegetables, and they have to eat less trans fats, and they have to limit their starches. Now we're talking about hygiene. Wow, that's a lot of stuff. But we need to talk about hygiene. Not because they're becoming more odoriferous, but for these reasons. So oral care and dental visits, we need to help them monitor, because all of our oral cavity is a huge, big old capillary bed, and blood sugars damage capillary beds. So we need to make sure that they're getting regular oral care and dental visits to make sure that they're maintaining their dentition as best they possibly can. The other thing that we're going to need to work with them on is regular bathing and foot care. Regular bathing, because they have that higher incidence rate or higher likelihood of developing a yeast infection, candidiasis. But that foot care becomes huge important. So we're going to be inspecting them daily. And the best way to do that is through a mirror, because there may or may not be a whole lot of mobility. Like, not everybody can put their ankle on top of their knee and take a look at the bottom of their foot, especially as we age. There's some joint problems that prohibit that. But if we can get them a mirror, like whether it be a full-length mirror on the wall or a different mirror that's just propped up against, like a smaller mirror that's kind of propped up in an area that can be used to be able to take a look at the bottom of the feet, they need to be inspected daily. They need to be wearing properly fitted shoes with sturdy soles. So not only can they shouldn't be going barefoot. They shouldn't be buying dollar store flippies either. They need to be wearing good fitting shoes, because if they get rubs and things, they have decreased wound healing. So if they get a blister from an improperly fitted shoe, that could be a really big deal. If they have a sole on their shoe that isn't very sturdy and it allows things to penetrate, that can also cause foot injuries. That's a really big deal. And then how to monitor and treat wounds and when to report to the healthcare provider. The reason why I always think of foot care as a big darn deal is because we want people to keep their feet. And improperly managed diabetes and improperly managed personal hygiene when it comes to foot care can cause a person to lose their foot. They lose their mobility, their lifestyle changes even more. They have bigger psychosocial impacts. It can create a whole cascade of negativity from one blister, from one improperly fitted shoe, or in the case of that one client of mine, from one thumbtack on the floor. We should be encouraging them to carry medical ID at all times, including a medical alert or an identification card, and plan ahead. So when we're traveling, our activity level is different. We might be a lot more active. We might be a lot less active. We might be a lot less active to get to where it is that we're going to be more active. Let's say we're planning a vacation to the Rocky Mountains in Colorado. We have to get there somehow. Then maybe we're going to be going hiking. So that's going to be more energy than maybe what we use now, especially since the altitude, et cetera, et cetera, et cetera. So making sure they have more than enough supplies and equipment, making sure they have snacks in their carry-on, making sure they have TSA approved snacks in their carry-ons and they don't get seized going through check-through, going through the security system. Being aware of what those TSA guidelines are so that they can be successful when going through. When they're carrying a medical alert or an identification card, their lancets become medically necessary tools rather than weapons. Legit. And you may consider having a letter regarding need for supplies and a plan for crossing time zones. If they're going from the East Coast to the West Coast, if they're going from here to Hawaii, yay, let's go to Hawaii. If they're going from Minnesota to Hawaii, or perhaps you're going Minnesota to Japan. My friend just got to travel to Japan to teach English for a year. Or maybe they're going to Europe. Those are all like 6 to 12 hour time differences that I mentioned there. So they're going to need to make some adjustments because they have to have a pretty regimented eating program because they're trying to keep their blood glucoses at normal levels. And so that means, how are you going to make adjustments if you're 12 hours ahead when you need to keep to a regular eating schedule? Those are things like, yes, travel, but we just need to be making good plans for travel. Here are some examples of either cards or a medical alert bracelet. And then let's talk a little bit more about patient and caregiver teaching in that ambulatory care setting. My goal whenever I had a client come in for diabetic related stuff when I was doing inpatient was to never see them again. Like if we could get them set up with great education, inpatient and ambulatory care resources, hopefully we never had to see them again for problems and complications with their diabetes. So goal for self-management and diabetes is to match the level of self-management to their ability for active participation. The more they can own the process, the better the outcomes will be. We're going to be taking an empowerment approach where they're using informed decision-making. We're going to be avoiding negative and judgmental messages. We are their partner in care. We are not their caregiver. And let's look to address barriers to effective management and help them identify resources that would be appropriate. We are also going to be doing an assessment, of course, initially, and we're going to be reassessing frequently as well. Providing them different resources, such as the American Diabetics Association resources for patients. Sometimes we may even provide things to the healthcare providers. There are a variety of different things that are in your text, such as informatics in practice with patient teaching using smartphone apps. Hello, welcome to 2022. As well as complementary and alternative therapies. There may be different herbs and supplements that our clients are taking because they're natural, but they may be impacting their blood glucose for better or for worse. An expected outcome. So how do we know that we was working? The client can state key elements of the treatment plan. The client can describe self-care measures that may prevent or slow the progression of chronic complications. The client maintains a balance of nutrition, activity, and insulin availability that results in stable, safe, and healthy blood glucose levels. The client is free from injury from decreased sensation in the feet, and the client implements measures to increase peripheral circulation. Notice that my evaluation was the client and then the bullet point, the client and then the bullet point. This is really something that they own. The more they own it, the better their outcomes are going to be. I'm going to stop sharing the slideshow because that's my last slide. Thanks for coming along with me on the diabetic journey, so to speak, for diabetes mellitus. I hope to see you in class. Please reach out if you have any questions. We'll be going over the slideshow briefly in class as well, but bring questions to class too so that we can have discussion. Because if you've got a question, most likely somebody else does too. Have a good day.